Hello, I'm Chris Chodo, and this is How Do Cognitive Behavioral Therapy Interventions Improve Quality of Life in Patients with Multiple Sclerosis? Cognitive behavioral therapy is an effective intervention at treating the underlying causes of fatigue, mobility, strength, patient compliance, and quality of life. Each study utilized various forms of CBT for a variety of symptoms and comorbidities associated with MS, which suggests the effectiveness and diversity of CBT in treating patients with MS. Still, more research should be conducted, and current practitioners would greatly benefit from continuing education in CBT. The first study is a randomized controlled trial with level 2 evidence. Participants were selected from 10 Italian MS centers associated with the neurophysiology unit of Brescia Hospital. Interventions investigated were executive function impairments, which were met with Plan A day software, and this focuses on scheduling dates and organizing duties. Individuals with memory deficits were asked to recall details of stories provided during treatment. Those with attention or information processing issues were given specific bits of information at increasing velocities. The control group, though, received an A-specific neuropsychological intervention that utilized conversation about the participants' perception of the disease and life. This group was not given exercises for cognitive ability or treated for depression. A total of 14 assessments were provided to measure the aforementioned cognitive variables. And these results indicated that the treatment group had the least symptoms post-study, verifying the efficacy of specific psychoneurological intervention as compared to an A-specific intervention. Sample size and participant compliance were limitations, though, and participants treated in a standalone facility were compliant. However, those treated from hospitals were not. The second study is a randomized controlled trial and presents with level 2 evidence. 72 subjects, all female, were selected from MS clinics of Kashani and Al-Zahra hospitals. Participants must have scored a 5 or higher for quality sleep based on the Pittsburgh Sleep Quality Index and a positive diagnosis of MS according to the McDonald's criteria. CBT interventions provided to the treatment group were learn a cognitive technique, learn a behavioral technique, group discussions, homework, and relaxation techniques. A total of 8 sessions were held once per week for 90 minutes. The comparison group also participated in group discussions, but these were not intervention-based. The topics of discussions were on feelings of the disease and experiences. There were only one outcome measure, which was the Pittsburgh Sleep Quality Index. The intervention group experienced a significant increase in quality of sleep, and the sleep quality dimensions were described as intellectual quality of sleep, sleep sufficiency, delay in falling asleep, duration of sleep, sleep disorder, consumption of sleeping drugs, and dysfunction during the day. This is another form of CBT with a positive effect on symptoms associated with MS. Limitations were due to individual response to treatment and environmental factors, as they have an impact on perception of outcomes with CBT. The third article is also a randomized controlled trial with level 2 evidence. 127 subjects were selected from the MS Society of Kaiser Permanente Medical Group of Northern California. The intervention group received CBT via telephone to encourage behaviors and enhance coping, while the control group received supportive emotion-focused therapy. Outcome measures were utilized to assess levels of depression in the participants. Through the measures, the researchers found a significant difference in depression and anxiety, to which both could predict post-treatment depression. The limitation, though, to this study was that measurement of insomnia was conducted by a depression interview, and measurements of dysfunction during the day were not taken. And lastly, the final article is a randomized control trial, also with level 2 evidence. 42 participants were selected from the Regional Reference Center for MS. The treatment utilized here was eye movement desensitization and reprocessing, which is a coping strategy utilizing external stimuli or eye movements by the therapist while the participant undergoes emotional disturbance. The control group received relaxation therapy through breathing, visualization, and cue-controlled techniques. Outcome measures here were all related to PTSD, depression, and anxiety. The results were that 100% of participants in the treatment group displayed no signs of PTSD post-treatment. And finally, the limitations were a small sample size and that depression was likely present and undiagnosed in some of the participants. So in conclusion, each of these articles give promising results to the effects of CBT in occupational therapy practice. I encourage you to explore these avenues in continuing education. Thank you.